There are two specific complaints that I hear from women all of the time that happens in perimenopause and menopause. And that is the loss of libido and the loss of hair. Now, I know those two don't sound like they go together, but hold on. Unfortunately, the remedy for a low libido can cause or contribute to hair loss. And it leaves us with a bit of a conundrum. I often hear from our female clients, I love my testosterone therapy. My libido's back, but now I'm losing my hair, or I'm growing whiskers, or I'm getting oily skin or acne. Well, ladies, today I'm hoping that we will find some solutions to this because my guest is a real expert on all things hair loss, but also on women's health and women's hormone health. And my guest today is James O'Hara. He is a family nurse practitioner who utilizes an integrative approach to health, which combines lifestyle interventions, appropriate supplementation, and medications when indicated to empower patients to feel better and live longer, healthier lives. And so, welcome, James. I'm so happy to have you here.
Hi, Karen. Thanks so much for having me. I'm excited to get started.
Yeah, so I found you through Dr. Kyle Gillette because I heard him on Huberman's podcast, which I think probably a lot of people found him through that. I would assume. And I was just telling you before we were recording that I then went on to start listening to your guys' podcast, and you two work together in the same clinic. And you guys just really bring a lot of new information to the table. Well, I don't know if it's new, but just different information, we'll say, to the table when it comes to hormones and the female health, that whole world. You guys really know a lot, and you have taught me a lot. And so I really appreciate that because for me, it's actually really hard to find information that I don't already know. So I wanted you to come on the podcast because something that you guys talk about a lot on your show is hair loss. And I know that a lot of it is towards men, but today we're going to talk about how this can apply to women's hair loss because it is such an issue. And I don't know, do you find that hair loss just in general in midlife women is something that you're seeing a lot of as well?
Yeah, I would say so. And I mean, first of all, thank you for the kind words, and appreciate you listening to the podcast and excited for today's podcast that we're going to do. But absolutely, I mean, whether it's men or women, yeah, they both have a lot of overlap when it comes to the inputs and outputs to have a full, healthy head of hair. And a lot of times you see changes in the perimenopausal time period, and definitely postmenopausal. There's changes in hair quality, skin quality, but there's things you can do about it, and you don't
Yeah.
have to always have a trade-off where you're giving up something in order to achieve something that you want, like you mentioned, sexual health. You don't have to give up your hair to have a good libido. Um, Most of the time, we can find a very nice balance to get the best of both there and minimizing side effects.
Yeah. Yeah. And do you guys deal a lot also with sexual dysfunction in your practice? You guys had a great podcast episode actually all about sexual health, and it was super interesting, which is why I wanted to talk about it today. But do you find you're seeing that a lot in midlife women as well?
Absolutely. And everyone wants to have a healthy sex life, a healthy sex drive, and everyone wants to have healthy hair as well. And the sort of triad that I describe for sexual function or sexual optimization is you have the actual, blood flow to the organ, and that includes for women, blood flow is important. You have the ability to relax or activate the parasympathetic nervous system. And this probably has to do a little bit with oxytocin, and managing stress levels and sort of having the ability to kind of shut off other parts of the mind and things that are going on in your day to day. And then you have these sort of drive and arousal, which I correlate with dopamine. And there's some, reflexes and nervous things in the spine that happen. But those are the three main things that I think of when I'm talking about, what is going wrong in terms of someone's sexual function. So we take a careful history and try to unwind, okay, which portion is it that they're struggling with? Is it that they can't reach climax? Is there an issue with lubrication? Are they so stressed out that they just can't stop thinking about other things? You kind of figure out what exactly do they mean by, low libido, because that can mean very
Hmm.
different things to very different people.
Hmm. So with today's conversation, we won't get into the psychology of the sexual health and libido because that's a whole episode all on its own, which is a big issue, of course. Like I'm not discounting that. But today I really want to focus on women that had a healthy sex drive and then they've hit perimenopause or menopause and it disappears. And so are you what's driving that? You just mentioned like oxytocin, dopamine. Like I don't know if a lot of women even put that into it. A lot of women actually focus on things like testosterone being the cause of it. But what hormones are we seeing impacting a woman's libido in midlife?
Yeah, primarily the two that I would think of would be testosterone and estradiol as the major players there. Dopamine could be considered a hormone and a neurotransmitter. Technically, neurotransmitters are hormonal signaling agents. And then progesterone to some degree, because that can have some GABAergic activity, which can kind of shift you into a more parasympathetic state. So really, all of the so-called sort of sex hormones do have a major role there. Certainly, the main thing you would think of with estradiol is things like vaginal dryness, which can lead to painful intercourse. The testosterone, it also does help with lubrication, but it is more what I would look at from a drive standpoint. So the actual motivation, the pursuit, the desire to be intimate with someone. And for those that don't know, oxytocin is sometimes called the love hormone, and it's related to primarily pair bonding, is how you could think of that in simple terms.
And do we see oxytocin going down with the sex hormones in menopause?
I don't know that there's a specific change in oxytocin. I'm not aware of any data published on that, but I
Mhm.
would assume if you're not having that regular intimacy, it's a little bit of an extrapolation here, then you're not going to get the same pair bonding reinforcement, the same positive reinforcement with your partner, which we know is important for long-term happiness and the relationship as a whole.
Right. And besides with the lubrication with estrogen, I definitely see there's something about estrogen, and I don't know what, and I'm wondering if you do, that helps actually the drive as well in a lot of women, like more so sometimes than testosterone, where it's like we can give a woman testosterone, she doesn't really notice much. And you replace the estrogen and she goes, "Oh, there's the sex drive. Now it's back again." And it's not about the lubrication. It's more about that like actually wanting to have the act of sex.
Yeah, and we know that happens when you replace, like, let's say someone goes through menopause, and a lot of times you can see this on blood work where the hormones just fall off of a cliff, meaning estradiol level was, 100 a month ago, and then they just happen to get another check, same, supposed phase of the menstrual cycle that they're in, or maybe they're kind of irregular in the perimenopausal time frame, and you see all of a sudden that estradiol levels are now, sometimes undetectable, sometimes at 10, and we know based on the studies looking at hormone replacement therapy, even with some of the older synthetic forms, that estrogen does improve, libido and function. Part of that may have to do with its effect on the monoamine oxidase enzymes. So the MAO I's, you have MAOIs that are monoxamine inhibitors. These are prescription drugs that are very rarely used anymore, but there are a number of substances and hormones that will slow the breakdown of your neurotransmitters. And this is probably where you see some of the subjective cognitive positive effects coming from estradiol replacement, as well as the libido, because now you're not burning through your dopamine as quickly, you're not burning through your norepinephrine as quickly. A very common story is, I used to love to read, and now I have a hard time, even remembering what I read the page before, and it's really distressing. You add back the estradiol, and I'm not saying this happens 100% of the time, but it's common enough where that person says, okay, now I enjoy reading again. I can actually remember what I'm reading. That's a very common effect that you'll see whenever you go from a, essentially depleted estrogen state to a replacement with bioidentical estradiol sort of state.
Oh, yeah, I did not know that. Um, what about, so is it the actual testosterone that helps with libido, or is it the dihydrotestosterone, or both?
It's more about a concept we call net androgens. So probably both have a positive effect on libido. The dihydrotestosterone is certainly much more androgenic. Even just testosterone, by itself is going to give you a downstream dopamine in the brain. This from some of the preclinical data. Obviously not from humans. We don't give them testosterone and then look at their brains post-mortem and see what's happening. But that does happen. So you've got a couple players there. Perhaps in some cases of androgen, not insensitivity, but people who are less sensitive to androgens, they may be a little bit more reliant on that DHT from a libido standpoint. But if you have enough net androgens where, let's say, you are pushing the testosterone level up, um, testosterone patches, testosterone creams, those are very well studied in women, even pushing levels above what they would be normally. So premenopausally, you may have a level of 30 nanogram per deciliter in a healthy premenopausal woman. They're pushing that level closer to 100 nanogram per deciliter. And even then they see a variable response to testosterone. I do want to stress that it's not 100%, just like nothing is. But they're pushing levels quite high. And at that level, there's a lot of data, including long-term studies looking up to 2 years, seeing positive effects on libido. That's one of the most well-studied applications for testosterone in women. We still don't have the approval. I think the United Kingdom will actually beat us to that because they have a trial ongoing now for a patch. So that'll be interesting to see.
Mm-hmm.
But you can push up the testosterone. If you're using a patch, using a cream, you're going to get proportionally more DHT because there's an enzyme, 5-alpha reductase. It's going to be at higher concentrations in the skin relative to, let's say, someone's doing a subcutaneous injection of testosterone once per week. So if they both have a blood level of 100 nanograms per deciliter, you're going to see a higher DHT level with the cream. So what do we do about the DHT level? That is where pharmaceuticals usually come in. That's going to be your strongest lever. But there are some natural 5-alpha reductase inhibitors as well. Things like saw palmetto, perhaps stinging nettle have some activity inhibiting that enzyme, not to the same degree or potency as a pharmaceutical intervention. But we're also going to be looking at the sort of spectrum or the degree at which the woman in front of us is sensitive to androgens. Some women will be able to take testosterone, never have any sort of hair shedding. That's not the average. So on average, we like to err on the side of caution because unfortunately, once you've noticed hair shedding or hair loss, receding, you've lost a significant number of follicles before it becomes apparent.
Yes. Nobody wants to see that. I heard you guys also talking about where to put testosterone cream and how that, like, that one, like you just said, that if you put it on your skin, you have a higher rate of it going into dihydrotestosterone compared to injectables. And then I heard you guys talk about that if you put it on the labia, that it also is going to increase the rate. But is that just the same as the rate as if it's just topical anywhere, or is it specifically that if it's on the labia, it's going to convert even higher?
Probably getting more net absorption total. So you're going to have a slightly
Right.
higher blood level if you're applying it labially. It depends on the thickness of the skin as well. So if you are applying it to your forearms, you're probably going to get relatively more permeability, more absorption compared to like your inner thighs, or if you were putting it on your back for some reason, somewhere where there's thicker skin, it's going to be more difficult for it to be absorbed. And with the creams, it's a great way to start because it's quick in and quick out. So someone can sort of take testosterone for a test drive. You get them up to a sufficient level, and if they're a kind of a responder or a non-responder. And libido isn't the only reason for someone to use testosterone. There was sort of a abstract from, I believe this was a group in the UK. They looked at their practice, and I think it was about 1,000 women who were given testosterone, and they saw things outside of libido that also had improved. So things like mood, cognition, energy. And these weren't like 10 out of 10 improvements in 100% of women. But it was more than 50% of women reported an improvement in mood. So it's not just, well, your libido didn't get better, you don't need testosterone. You kind of have to look at, okay, what are the pluses that you're getting? What are the minuses you're getting? And keeping in mind someone's history, asking about, did you struggle with acne as a teenager? Have you had a history of PCOS? Because PCOS, or more specifically, someone being more sensitive to androgens,
Mhm.
doesn't go away just because they're now menopausal.
Mhm. Yeah, because we produce testosterone not just in the ovaries. So I think a lot of women don't lose their testosterone in menopause, unlike estrogen and progesterone. So some women can hold on to their testosterone as they get older. So that's the difference there. Um, when it comes to helping a woman with the sex drive, besides the testosterone, are there different things that you guys like to utilize in your clinic, that's beyond the testosterone? Because some women are, and we're going to talk about this, like the whole alopecia or losing hair from taking testosterone. But are there peptides, like things like that, or oxytocin, like other hormones that you are seeing besides testosterone that you see actually helping women's improvement in sex drive and libido? Because one thing that I'm hearing so much about is topical tadalafil. Or is that how you say it?
Mhm. Yeah,
Which is like
tadalafil.
Viagra, right? So
Yeah,
topical, yeah. Talk to me about that.
yeah. There's a lot of sort of creams out there, custom creams that may have amino acids like citrulline or arginine and tadalafil in them to improve blood flow. You can do the same thing with oral tadalafil as well. So if you're getting just like a generic Cialis from the pharmacy at a low dose, that has about a 50-50 chance of improving some aspect of sexual function in women. So if there's not necessarily an issue with blood flow. If it's primarily just like a drive function, like it's like, hey, there's no issue in XYZ, it's just the drive. The tadalafil is probably not going to be the magic bullet there.
Okay.
That being said, getting a little bit more, intensity from an orgasm with more blood flow in the area, that can certainly happen, and that can be sort of a bonus, a reason to use that. Other things that we think of, and there are some FDA-approved therapies. There is the prescription drug, I believe it's fibanserin, brand name is Addy, which is sort of I think of it as a reverse SSRI. So we know that a lot of men and women that go on something like a Paxil or a Lexapro or one of these SSRIs do have a drop in libido and
Hmm.
difficulty with the dopaminergic signaling side of things. It's somewhat common for that to get stacked with another medication that's like a dopamine norepinephrine reuptake inhibitor, like a Wellbutrin, bupropion, and they sort of balance each other to some degree. But then you're sort of treating the side effects of one medication with another medication, get into a bit of a cascade there. The results are really variable with Addy as a sort of reverse SSRI. There's an FDA-approved actual peptide therapy, which is Vyleesi, the
Hmm.
bremelanotide. And that is available from some compounding pharmacies in a lozenge. I think the reason it is less popular is because it's a relatively high dose injection, and that could come with flushing and some nausea. And it's an injection. So, that's not something that exactly puts a lot of people in the mood, especially if someone has some needle phobia. It's not a great option for them. But that's an option, and it's available in different forms, injections, nasal sprays, sublingually. Um, and then there are things that are just generally dopaminergic, but don't stick around as long as something like the Wellbutrin or bupropion. I believe there was a talk show host that got sued because he was promoting off-label Wellbutrin and talking about how it's going to give you, 50 orgasms or something like this. And obviously that's not evidence-based, and he was just doing this because he got a big payment from the pharmaceutical company. That being said, it does generally directionally have a positive effect, but it has depending on the form, it can have a long half-life. So you can end up interrupting your sleep, sort of having a trade-off there. With an older medication, apomorphine, which actually is in no way structural to morphine. It just happened to be sort of I think, a byproduct of morphine synthesis back in the day. So the name stuck. That's what people always ask me when I say apomorphine. They're like, is this an opiate? Am I going to get
Morphine, yeah.
addicted to it? Yeah. You might get addicted to it, but not because it's an opiate. But it does drive dopamine signaling, and it's a very short-lived sort of think 2 to 6 hours it's in and out of your system. So it shouldn't be disruptive to sleep, or at least not as disruptive as something like a Wellbutrin XL, which has like a 24-hour active life.
How would a woman know if it's a blood flow issue?
So there's a couple ways you can go about that. Tadalafil is a relatively, benign medication, safe, doesn't have a lot of side effects. So you can do a, trial there. Blood flow primarily, we're thinking of like engorgement of the labia, engorgement of the clitoris. You can actually have a clitoral priapism. We think of that in the context of men, where they get a erection that lasts longer than 4 hours, doesn't go away, just like you've heard on TV commercials for decades now. The same thing can happen to women, but it's an extremely rare occurrence.
Oh, yeah.
So if you're not having that engorgement, then that could point to an issue with the blood flow. And then the question is that perhaps a rate limiting step in reaching your goal, whether that is, blood flow and then lubrication following that, or if that is, achieving a more robust climax, more intensity. Just because, things are okay or things are functional, doesn't mean that they aren't optimal. And there's nothing wrong with asking, hey, how can we make this better in a safe way?
Yeah. I find that most women, the complaint is more so like the desire just to even have sex, right? But I think that the blood flow issue is probably more prevalent than we think it is, or that we hear about, because I don't know if a lot of women even know that they would say, "Oh, my clitoris isn't getting engorged." Like, I don't think that that would really click in for a lot of women, or it's no longer getting engorged, or my labia is no longer getting engorged. Like, I don't know if too many people connect the two. I had a woman actually come on who was a sex expert, really well-known woman, Susan Bratton, and she that's all she talked about. That's what her big thing is the engorgement part. And so she had like
Mhm.
a supplement that would increase nitric oxide. That's right, right? Nitric oxide, to
Yeah.
blood flow to the area, and so and that was using citrulline, and I have heard really good things actually about citrulline being helpful in that area. So, but yeah, Viagra for women, it's not something that, yeah, we're just starting to hear about that, I think. Not, it wasn't really well known.
Yeah, exactly. And, if you're looking at, why is the blood flow not as much as it used to be, or why is that diminished? Why is there a problem there? It could even be similar. Like it's pretty apparent for a man whenever he has a lack of blood flow. Like that's a
Right.
very obvious thing. It's a little more subtle for women, but you could still have an underlying cardiovascular risk component there, because the arteries are going to narrow not just to supply blood to the penis or the clitoris, but also to the coronary arteries. So for both men and women, heart disease is still number one. So if there is an issue there, it can be a reason to look and see, hey, do I have any of these risk factors? Even doing something proactive, depending on age, you could consider a calcium scan. A CCTA would be even better. Not to derail too much, but we do want to think about, heart health and sexual health as having a lot of things that
Hmm.
are overlapping. And what's good for your heart is probably good for your sex life too. So things like exercise and just generally healthy things to do.
Yeah, you could almost use it as a like a bit of a red flag, 'cause I know guys do. If they're not getting erections, that they want to look at their heart health. And so for
Yeah,
women, it would be the
exactly.
same thing. I
Yeah, we
never,
call it
yeah,
the canary in the coal mine. Exactly.
right, right. In your guys' clinic, do you guys use certain peptides like PT-141 or melanotans, which are in that same family as the prescription medication Vyleesi, which is a bromatide? Is that what it's called? What do you
Yeah,
call it?
bremelanotide,
Bromolanotide.
essentially
Yeah.
the identical ingredient. So you have
Okay.
one that is, coming from the pharmacy, and if patients' insurances will cover that, sometimes you have to do a prior auth, you have to questionnaire, and there's a little bit of legwork involved. But if insurances are covering it, then why not give them this thing that is coming from their local pharmacy, and they're getting it for free essentially. I mean, obviously, they're paying for insurance; nothing's truly free. But we will usually go that route first, and then if they don't have access and they say, well, it's going to be $800 a month or $1,200 a month, like some of these branded drugs are, then yeah, we will prescribe essentially the identical, compound. There's certain sort of checks and balances that are in place there to make sure that we're getting patients a high quality product.
Wow. Yeah. I just ordered melanotan 2 for the first time because it just sounds like it's this wonder peptide. Like it hits on so many different levels, like helps with metabolism, immune system, gives you a nice tan, like, and it can help with your sex drive. But I hear that the side effects can be a little bit deterring, like because you can get nauseous from it.
Yeah, and that usually is if people are pushing the dose a little bit too much,
Mhm.
not doing a sort of test dose. It's pretty uncommon that I would prescribe the melanotan 2, just because it does have that sort of skin pigmentation. Some people find that as a pro. There may eventually be some data that suggests like, hey, this is actually a good thing because now people have more melanin and they're less prone to damage from the sun, and we're actually going to reduce the chances of skin cancer. But it can cause things like, moles and existing hyperpigmentation to get a little bit worse. Usually that's going to be dose dependent. So I don't have a whole lot of experience with that one. I
Okay.
personally tend to stay away from it myself with a personal history of some pre-melanomas and family history of melanoma. But I do know people who have used it and they seem to get sunburn less, have a good response to it, and seemingly, nothing negative that we can put our finger on.
And do you see it being something that actually works for sex drive in women? The Vyleesi, the melanotans.
Yeah, I do. And there's a plausible mechanism behind it. It acts on the melanocortin receptors. So these receptors are also activated by sunlight. I think, thanks to Andrew Huberman, more people than ever are outside getting their sunlight, getting their morning sunlight specifically. But you sort of think of you're looking at the animal kingdom, even when the days are longer, the springtime is here, and then animals are outside, they're getting more sunlight, they're getting more melanocortin activation. And that may play a role in sort of, the mating season, the drive there. And I don't think that's entirely absent in people. I know some people, they report, they go on vacation and libido is great, right? And they come back home and of course they're re-entering into a slightly higher stress environment. But a lot of people, on their vacations, they're outside exploring, they're on the beach, they're getting sunshine. Sort of all these pieces come together. You've got the stress management, you've got sunlight, you've got time, you're relaxed, and everything kind of comes together. So we think, how can we like package that up a little bit and take that home? And directly stimulating the melanocortin receptors is probably a way to capture a little bit of that effect.
Oh, okay. So when we replace the testosterone, we see it actually working pretty darn well for women that lose their libido in perimenopause and menopause. I always say it can't shift if you've never had a libido and then you're hitting perimenopause and menopause. Typically, we don't see testosterone working very well. Sometimes, but usually
Mhm.
it's like you got to get under and look at the psychological stuff, in women like that. But for women that had lost it going into perimenopause and menopause, putting in testosterone therapy on the higher end dosage a lot of the time too, it really works. I mean, I hear it all the time where women are just like, thank goodness my libido is back. My partner's happy. I'm happy. And then a few months down the road, they come back and say, ah, I'm losing my hair, Karen. Like, I don't want to lose the effects of my testosterone. It's not just libido. Like you said, they're feeling more energetic. They're able to maintain muscle tissue, like body composition's better. All of these things, like energy's better. I always say testosterone, it gives you your woman balls. It makes you want to like get out there and get stuff done and, like be a little bit more aggressive with things. And so it's a really like it's a sad thing for women because it's like it's this toss up, but God forbid if a woman loses her hair. Like that's like so tragic. I lost a whole bunch of hair after getting COVID.
Mhm.
And it was like the first time that that's ever happened to me. And it was so upsetting and so disturbing because I was like, no, like it's one thing for a guy, but for a girl, it's like a million times worse because our hair is, so much to do with our looks. And so How can we figure this out? Because I know you are such an expert on hair loss, and you yourself have hair loss issues, correct? Well, you don't looking at
Yeah.
you, but this is because you're doing what you're going to teach us.
Yeah, I started losing my hair very early on. I mean, if we're looking at the male relatives in my family history, basically all of them were slick bald on top of their head. So it's just sort of something that I have a very heavy genetic predisposition to. I think I was 21, 22 whenever I first noticed it. And it was in some, bright light, sun shining down. I'm looking at the picture and I'm thinking, oh, like I can actually see my scalp there. That's not right. And then, I didn't really do anything about it at the time, but then realizing, hey, this is like progressive and sort of doing research, being in the health field at the time. There's definitely things you can do in order to preserve what you have and also get regrowth. And sooner is better. So we
Right.
look at sort of all of the factors. So let's say this woman is doing great on testosterone, and she comes to our practice. She says, "Hey, this testosterone is great. Don't touch my testosterone. I want to keep my testosterone. I want my libido. I want that benefit. But can we do anything about the hair?" We're going to go ahead and look at all the moving parts there. So one of the things that can happen with testosterone is you are producing more red blood cells. And when you do that, you may deplete your ferritin levels. We know some women are sort of borderline iron deficient or have a history of anemia,
Mm.
especially those women. They may be using up their iron stores to make more red blood cells, and that can cause a sort of telogen effluvium, which is like a shedding phase, just like you described. Like this happens post-infectious or post-stress. After COVID, very common to have, up to 50% of those follicles just enter a resting phase. And that doesn't mean that those are never coming back, but it can be very shocking because it's a very abrupt difference. And sometimes that can unmask an underlying androgenic alopecia. So this is typically where you see some recession in the temples, some thinning on top of the head, maybe some thinning back in the crown as well. So a male pattern baldness presenting on a woman. And the iron can sometimes unmask that. We look at thyroid because we know when we replace, testosterone or estrogen, those can affect thyroid function. It says right there in the package insert for any estradiol product that, hey, this can affect your thyroid values because it's going to increase your thyroid binding globulins. So you follow that because we know too high or too low on thyroid, that can affect hair growth. For most women, it's going to come down to the DHT that we'll talk about. But it's also a good time to take a look at sort of your vitamin and mineral status. There are a lot of good sort of catch-all hair loss multivitamins out there. Main things we're looking at are zinc, looking at selenium, looking at the iron levels, like I mentioned. You can check copper as well, especially if they are supplementing with zinc. You can sort of give yourself a copper deficiency in a sense if those two minerals will sort of compete for one another. Looking at the B vitamin status, just making sure all those boxes are checked. So the basics. And then you get to, the DHT, and it's not necessarily about the DHT level itself. It can certainly be helpful to measure to see, okay, what is their baseline conversion rate? In men, it tends to be between 5 and 10% of the testosterone. In women, it actually seems to be a higher percentage than that. And the
Hmm.
assays are not perfect, so they may be overestimating just a bit, but it's not uncommon to see a woman with a DHT level of 15 or 20 nanogram per deciliter, and their testosterone is only 40, 50, 60 nanogram per deciliter. So it's a relatively higher conversion rate. But the good news is that women tend to respond even better than men do to the interventions aimed at regrowing hair. So if you
Hmm.
take something like dutasteride, which inhibits the 5-alpha reductase enzyme, you're going to drastically lower the DHT level. It's not an immediate fix. Setting expectations is very important. You're thinking, hey, 6 months from now is when you might notice that there's a positive change here. In the
Oh.
meantime, sometimes we will use a little bit of a low dose of like maybe a half a tablet of oral minoxidil to speed things up if they're a good candidate for it. You do have to be careful with that. If someone has a orthostatic tendency, they tend to get dizzy. They're probably not a great candidate for that. And if you're looking 2, 3, 5 years out, the results are going to essentially be the same. You're just sort of speeding up the progress they're going to make, which a lot of times they're like, I want my hair back and I want it back yesterday.
What's minoxidil? Like, how does that work?
Yeah, so minoxidil is
Most.
an old, not very good blood pressure medication. It's the same ingredient that's in over-the-counter Rogaine for men, but it comes in a tablet form. I find that men can tend to tolerate using the topical if they're going to use it and use it 6 nights a week at least. They get pretty good results with it. Some people will say, "Hey, I just don't have the discipline for this. It's not going to happen." If they're only using it half the time, they're going to sort of end up in a permanent shedding phase and not really making any headway. Oral minoxidil has come out now, and it's been in use for quite some time. We've been using it in our practice. And lower is generally better in terms of managing the side effects. Um, if you push the dose too high, you can get hair growth, not just on the scalp, hair growth everywhere, get fluid retention, get lower blood pressures, because it is a blood pressure medication. But the reason that oral tends to be better for women is that if you are putting in some greasy product or some foam in on your scalp trying to get coverage, and women tend to have longer hair, it just sort of is going to throw a kink in your routine, and it's not something that a lot of women are able to adhere to. Some women, they love it. They say, "Oh no, I'd rather use the topical. I don't want to risk having an increase in my arm hair growth or chin hair growth or things like that." The risk is low if you're using appropriate doses. So, 1.25 milligrams is a half a tablet. That's a very low dose, and that's enough for a lot of women to respond really well to.
And so it's helping the hair to grow. It's not doing anything with the 5 alpha reductase.
Exactly. So this is a trend I see a lot of dermatologists. They say, "Oh, like, this woman is having some hair loss. Let's put her on just some, minoxidil, and that will improve the hair growth." And it will probably buy you some time. It's not addressing the underlying cause, though. So it's not addressing the cause of the progression, which for most men and women is an androgen component, the DHT. So
Mhm.
you will get, within 3 months, probably 20, 30% more hair volume, depending on how well of a responder you are, how well you respond to it. But it's not going to build you long-term progress. So basically, after 3 months, that's what you're going to get out of it. Whereas with something like a dutasteride, you could potentially see, progress that continues all the way out to 5 years, um, even if that's the only thing you're doing, depending on how early you start addressing things.
Hmm. Can you tell by how someone is losing their hair what the root cause is? Like, you were saying like around the top, for instance, it's more about that DHT. So like between like thyroid, iron, even estrogen deficiency, testosterone overload, or too much DHT, are there patterns in the baldness?
Yeah, there certainly are. I sort of think of three bigger patterns. Then there's a couple of rarer, like scarring types of alopecia that would be referred to a dermatologist. But you have like alopecia areata, which is a sort of circular patch where you may just have the side of your head here, and there's like just a chunk of hair missing. And that's autoimmune related. A lot of times you can inject a little bit of corticosteroid in there and get it resolved quite quickly. There is telogen effluvium, which can be induced by hormone changes after childbirth, iron deficiency, a viral infection, severe stress, and that can have varying degrees of intensity. Some people will lose all of their hair after a major life stressor. Some people will lose 25%, 50%. But I know a lot of cosmetologists and hairdressers out there noticed, like post-COVID, that people were having a lot of these baby hairs. They're like, "Oh, did you like lose a lot of hair because of COVID?" And a lot of women didn't notice because they have a lot of hair volume. They're like, "Oh, I don't know." Like, well, you've got all these new baby hairs growing up, so that must be what it is. And that's sort of what you would see with a iron deficiency state, a state of estrogen deficiency, um, thyroid. You're going to see some texture changes with thyroid, generally like a more coarse and dry texture with hypothyroidism, as a general principle, not as a hard and fast rule. And then with the androgenic component, you're going to see probably more proportionally a widening of the part, more relative thinning on top of the scalp, recession of the temples, and some thinning in the crown. So you may have very thick and dense hair on the sides of your head, the back of your head, but on top of the scalp, that would be relatively less hair volume. So that's kind of the three patterns you can look for and kind of determine, okay, what is the underlying cause, and then realizing that most of us, both men and women, are going to be sensitive to the androgen component at some point in our life.
Hmm. And just your thoughts, because just rang a bell for me when you were just talking about COVID, because that's when I lost mine, was post COVID. I lost all this hair. And I have a friend of mine who didn't get COVID until like just a couple of months ago, like last December.
Oh, wow.
So several years later,
Hmm.
but she's had probably, I think, 4 or 5 um, vaccines for COVID. And her hair loss started around the time that she started getting vaccinated. And she says, I have no idea if this is why, because I had told her that I had lost my hair from COVID. And
Hmm.
I thought, I wonder if it would, it's this, if it would works on the same kind of pathway where you're not maybe getting the infection, but you're putting the infection into your system. Would it could it cause hair loss? And then I looked it up, and there was some reports on it for sure that said that that was a side effect of the vaccination, but it wasn't super prevalent. But have you would that work the same way?
Probably not because it behaves exactly the same way as COVID, but because it's generating an immune response, and that can be, taxing on the body in various degrees.
Hmm.
So really any medication in theory, I mean, if you're looking at the package inserts and how side effects happen, even, common sleeping medications or antidepressants have hair loss listed. So I'm never going to say never, no, it's impossible. This isn't making you lose hair, because there's always that chance, but it isn't something that I would think to be a particularly common occurrence.
Hmm.
But, being immune mediated, there is a sort of underlying mechanism we could point to there.
Right. So let's talk about dutasteride and finasteride, because these are the two most common medications that are given to women that are having the hair loss or the high DHT symptoms like oily skin, acne. So usually they're given dutasteride or finasteride. And you said it's good to hear that people have to be patient, because I do hear from some women, a couple months in, it doesn't seem to be working. And so it is something that's for some women, obviously they have to be patient, and it will start to kick in after that time period. Um, you hear a lot about this post finasteride syndrome in men. Is there detriment to the drug in women? Like, what's bad about it? What are the side effects of taking these drugs? Because women are usually pretty like, oh, I don't want to take a drug to stop this like that. I don't want to be on a medication for the rest of my life just so I can have myself a libido. So is it a terrible drug? I mean, you're on it, right? Kyle's on it. If you guys are using it. So obviously it's not that bad, right? So what are the pros and cons here?
Yeah, it sort of goes back to the concept of net androgens. I mean, with any medication, you always have the potential for an allergic reaction, hypersensitivity, these sorts of things where people have some side effects from it. Um, the side effects would probably be the most substantial in women who have a low baseline testosterone, and a lower DHT to begin with. They're still going to get some improvement. There are studies looking at, finasteride, even the 5 milligram dose in premenopausal women and postmenopausal women. Caution does have to be exercised there due to the potential teratogenic effect. So the effect on a developing fetus, if it were to be a male specifically. So that's a discussion to be had. But as far as the side effect standpoint, there was one study that pointed to as high as a 20% incidence of decreased libido in women taking finasteride. Now, dutasteride is less well studied in women, but based on the head-to-head sort of analyses that are done between dutasteride and finasteride in men, they tend to have either the same amount or less side effects on dutasteride. So it's very rare that we would put someone on finasteride in our practice just because we believe the adverse event profile is not quite as good. An
Okay.
interesting tidbit from the study I just mentioned is that none of the women that had the lowered libido chose to discontinue the drug. So at that point in their life, their hair was a higher priority than the libido. And that's a trade-off that, we have a discussion with a lot of women. It's like, well, I know we want to have the testosterone, not have to do anything medication-wise, not have to take anything with it. And have the hair too, but you can't always have like the perfect scenario where you change nothing and get the outcome that you want. But it is nice to make sure you are looking at sort of the ancillary things, especially nutrient status, because very few people are eating a well-rounded diet. Probably more so in the audience of this podcast, of your podcast. They probably have a better idea of what's what from a nutrition standpoint. But it's still good to double check those things because sometimes there are some like malabsorption features we can see and top those things off.
So you guys don't see like different blood markers changing because somebody's on dutasteride long term then? Like it's not going to affect our cholesterol or blood sugar or anything like that?
No, I haven't seen those changes. It does change the serum DHT. That's the easiest thing to see change. A lot of times you'll get sort of positive, bonus things that you weren't expecting. So whether that relates to oil production or acne, and it's not as if some of the other treatments out there, if you're looking at like lasers or light therapy or even topical prescriptions, those sorts of things. But if someone is like, yeah, I have a pimple once in a while, my skin's been a little bit more oily since I've used testosterone, then a lot of times it gives a nice balance to that, to where they're still getting the benefits. They're still, loving their workouts in the gym, and they're just like, well, I don't have to like blot my face 4 times a day with these wipes because I have this oil production. It seems to be more in check now. So I would say that there's more on the positive side, but I'm not going to say that there's never a woman who is somewhat dependent on the DHT from a libido standpoint. And at that point, we may have to look at, okay, what are other ways we can optimize libido outside of testosterone? Or maybe lower the dose of testosterone because we still want the benefits on exercise and bone and mood, but we don't have to push it quite as high because we're going to use another means to get to the libido standpoint we want to.
And do you find that the herbal DHT blockers work very well, like saw palmetto? Like, will you guys typically try those first with a woman, or would you just go straight to the dutasteride?
A lot of this comes into shared decision making with the patient. So we're upfront with what the results are likely to be. So what has more variability and what has more consistent outcomes. And there are patients who are more naturally minded, patients who are more on the like just tell me what's going to work the best spectrum of things. So I mean it works well enough that there are products like Nutrafol and there's one that starts with a V. There's a number of these out there, and they all have saw palmetto and zinc and vitamin D and all these things in there. And they've done clinical studies, and you see some improvement. So if someone is pretty naturally minded, you can sort of recreate that product at a lower cost. As long as they're not using a proprietary blend, you can look and say, okay, it has this much zinc, this much selenium, this much saw palmetto, it's got iodine for my thyroid. And you can sort of, look at a similar multivitamin, add some saw palmetto to that, and get a product that doesn't cost $100 a month. So that's one option. Even if someone's, listening and thinking about, well, how can I do this? I don't, my doctor's not going to prescribe me dutasteride. What's something natural I can try first? That can be a great option, a great place to start. It's not going to hurt things.
Mhm.
And I would say still I would have some concern about using that in the time window of pregnancy, just because we know that just because something is natural doesn't mean that it's always perfectly safe with no downsides. If it's inhibiting the same enzyme, it's probably having a similar effect just on a smaller scale.
Right. Do you ever combine the two? Like, would you ever put someone on dutasteride and a saw palmetto nettles combination? Or
Generally, no,
no? Okay.
and not intentionally. Let's say if someone was taking that already and we added the dutasteride on top of it, or if someone said, I want to be 10 out of 10 aggressive and do everything I possibly can to
Right.
address this, then that would be a case to do so.
Okay. That's good to know. Do you ever use copper for hair growth? Topical copper or injectable copper on the scalp?
Yeah, so there is the peptide GHK copper that I believe is already in a lot of over-the-counter, cosmetics, creams.
Mhm.
You can get higher concentrations of it. I believe there was one trial using like a 3% formulation that showed some results in terms of scalp hair growth. It may have been combined with one other ingredient, something like that. But it may have some efficacy there. It's not as potent as even like a topical Rogaine or minoxidil. So that is going to be a more potent driver of growth. but it's not going to hurt anything. So at worst, it's something that's, neutral and does have some regenerative properties. We don't really know a lot about the GHK copper and the levels. There's not actually a commercial test to measure those. In theory, to pick the perfect person for to get the ideal response to this supplementation, you would measure their GHK copper level, say, okay, this is where your level was when you were 20. It's dropped to this point. So, hey, you're a good responder. And maybe you have another woman who's 54 and she's still got top-notch levels. Like they're great. It's just like a 20-year-old. And in her case, she's probably not going to gain a lot from adding more in because she already has a sufficient level. So that would be the ideal way to do it. But right now it's sort of a trial basis because, as far as I know, there's no commercial way to gauge that. You can certainly look at copper status. That can give you a good clue. And a lot of times if we see like both a zinc and a copper deficiency, we're adding in a nice balance of those two so that we don't skew one way or the other.
Do you ever use spironolactone? And maybe you could explain to the audience what that is.
Yeah, so spironolactone is a anti-androgen, also a blood pressure medication. Kind of an interesting theme there, but it's what we call a potassium-sparing diuretic. This is if you take it in the pill form. I use it most commonly in a 5% topical solution from a compounding pharmacy for acne. There are some shampoos that have that in there. Like you can sometimes get a nice compounded shampoo that's got caffeine and it's got maybe some ketoconazole in there, which is an antifungal that also has some anti-androgenic properties. Other antioxidants that are sometimes in these shampoos, proprietary formulas, but those are kind of the big three I think of. I don't tend to use it a lot systemically, like someone taking a pill of it, because it's going to then target androgen receptors. It's going to block those everywhere, not just in the target tissue. So it's not that it's going to make your testosterone that either you're producing endogenously or the testosterone you're taking completely useless, but it is going to antagonize or oppose it to some degree. And then it can also cause some urinary frequency. You have to monitor the electrolytes. When you're using it in a topical form, you're not going to get that systemic absorption. So I think that's the ideal use case for it, is a higher concentration topical product. But that being said, there are some women who are very androgen sensitive. Perhaps they have a history of PCOS or cystic acne, and they're getting really good results from that. I'm not always going to say like, oh, hey, no, you're doing it wrong. We have to change this to a topical. If their electrolytes look good, they're not getting any bothersome side effects from it. We're making sure that they have a sufficient androgen status, so we're not tipping them to being in sort of an androgen deprived status. That would probably slightly increase the risk of a estrogen receptor positive breast cancer. Then, we're addressing all these things. It doesn't seem like there's a lot of downside to it as long as they're doing well.
Okay, good. Okay, I think we've covered it. So that makes me feel better about the dutasteride because I'm always hesitant to tell women that, well, you can just take this other drug to mask these problems. But it's nice to know that it sounds like it's a very safe medication and that it works well for this problem. And it's a matter of patience that it can take a little bit of time to kind of kick in and work for women. But you guys like it. You guys use it often in your clinic. And so you're obviously seeing that this is one of the better therapies for hair loss in women. So I think that it can definitely, or is it the same dosage between men and women? I have no idea.
Generally, yes. There's only
Okay.
one commercial dose. It's half a milligram. In
Okay.
the clinical development studies, they gave people as high as like 40 milligrams. And with a loading dose like that, it would be in your system for at least 6 months. We tend to do a sort of start low and go slow process, whether we're working with men or women. So maybe there's a little bit hesitant. You say, hey, let's just try it, you know, 3 doses a month. You take it every 10 days. Like you're probably not even realize you're taking it. And then you sort of increase. Now you're taking it once a week, twice a week. At 3 times a week, you're probably going to get 90% of the benefit of taking it daily because it has a longer half-life. So it's not something you have to take every day. A lot of people will just sort of put it in a pill organizer. Okay, I take this on Monday, Wednesday, and Friday. And it's a lot less of a pill burden because a lot of time people are taking supplements and it's like, well, I have to take another thing now. So reducing the number of pills is always generally a positive thing if you're looking at the optimization side. So the doses are the same. Women have DHT too. Kind of a funny story. I've had this happen several times now where pharmacies are like, this is a drug for men, and you prescribe this to a woman. Like, what's going on here? And I've gotten to the point now where I just write on the form, women have DHT too, and we fax it back. And now they're dispensing it. So our staff kind of gets a kick out of that.
Well, it's just like there's no testosterone for women. Like there's no, you can get it compounded and that's it. And it's like, hello, medical system. Women have more testosterone than estrogen and progesterone when we're fertile. Like
Yeah.
it's a very important hormone for us too. So come on. Yeah, it's terrible. It's terrible. I feel like it's changing, but very slowly, very slowly. So you guys are taking on new clients, correct?
Yeah, that's right.
And do you work virtually with people or just people in your state?
So both. We have a physical location that's right there on the border of Kansas and Missouri, but we do telemedicine as well. A lot of people will fly in. They'll see us. It's certainly not required in certain circumstances. Maybe we do have to have an in-person visit. But yeah, we accept people in basically all of the 50 United States, not internationally at this time, because we do get a lot of questions about that.
Hmm. Can you guys prescribe in every state?
Yeah. Mhm.
Oh,
Yeah,
great.
context depending. So, occasionally someone, like I said, if we're talking about controlled substances or if there's, especially like Schedule 2, then people would have to be seen in person. We're not going to virtually prescribe Schedule 2 to, states, but between, myself, Dr. Gillette, other physicians, we do cover the entire United States.
Right on. Yeah, it's hard to find that. We do too at our clinic, which is a
Nice.
bonus. Yeah, that we
Yeah.
can in every state. And only in a couple provinces here in Canada. I'm in Canada. I'm not even in the States, but
Right.
we
Yeah.
mostly work with people in the States. But yeah, so that's good to know. And you guys do you're not hormones and hair loss. You guys do a full just medical practice, correct? Like your family physicians and you deliver babies too?
I do not. I'm a nurse practitioner, but yeah, Dr.
Okay.
Gillette has delivered many babies. He's a full spectrum family medicine physician. I've a little bit aligned myself towards the adult population, so that would be more consistent with like internal medicine. But yeah, we call our practice individualized medicine because we take care of each person as an individual based on their specific health goals or health problems that they have. And spend a lot of time sort of tailoring how do we build the best plan for this person with their resources and their time availability. That's what our practice is all about, whether someone's coming in with sleep issues or they have a family history of heart disease or they want to make sure they're doing the best screenings for cancer, family history of cancer. We're really looking at all those check boxes, like how can we give this person the best health span and the best lifespan.
Yeah, you guys seem to do such a great job of combining both worlds of functional medicine and conventional medicine and grabbing from both sides, which I think is really important to do because we can't discount prescription medications like things like dutasteride or other things that you're going to need but then you guys aren't doing the okay 5 minutes for each patient, see you later, just putting them through. You're actually spending time with your clients and trying to get to the root cause and addressing diet and lifestyle and having a very functional approach to it. So I appreciate that.
Yeah, no, thank you for the kind words. We're sort of building a bridge between functional medicine and traditional medicine. Because there's so
Mhm.
much value on both sides, and it seems like it gets kind of
Mhm.
siloed where one side will poo-poo the other side and say, well, this is
Mhm.
all nonsense or this is all nonsense. So we'd like to build that bridge and provide some balance.
Yeah, I've been hearing so much on social media, people with these constant comments of when we're talking about HRT of uh, or weight loss peptides. I know you guys are into those too, and as am I. And people saying, "Oh, that's big pharma. That's big pharma," and I'm not going to feed into big pharma. And I said on a recent podcast, I said, yeah, well, are you gonna say, "Oh, I'm not gonna feed into big pharma," when your kid's on a hospital bed needing some prescription medication to save its life? No, you'd be like, "Oh my goodness, thank goodness for big pharma." Like, Yeah, they're money hungry, whatever, or they're multi-trillion-dollar companies for sure. But so is how many other companies making money. It's like your grocery store people, they're making a good buck. So is your supplement companies, a lot of supplement companies, so we can't really like poo-poo something because
Mhm.
they're making all this money and it's big pharma. It's like, well, they have their place and we need them and we need to be grateful for what they do offer.
Yeah, absolutely. I think that's a great example. You sort of can really connect with someone by giving a example like that of like you can't say that it's 100% bad. Yeah, just like the food industry isn't 100% bad. People have to eat food. Yes, we wish food had less sugar in it, was healthier. But
Yeah.
again, food isn't evil in of itself.
Exactly. Yeah, there's always going to be big corporation and people making money and scamming the humans and whatever. But take everything with a grain of salt, and everything's got its purpose. So it's all good. All right. Well, thank you so much for coming on the show today. You've cleared up a lot of good things for people, and I can't wait to share this with my women who are having troubles with their testosterone therapy and hair loss. So I appreciate your words of wisdom, James, and thank you so much for coming on the show.
Yeah, thanks so much for having me on. This was great.